prefer to move to a more positive message, and I prefer to move to, in my opinion, what could be improved in diabetes. So following that perspective, I want to, this is my disclosures. I want to invite you for this outline. I would like to do a little work on the past, present, and future of primary care. I also would like to share with you some experiences in continuous quality improvement programs, what's going on in the real life, what it means, complexity, clinical inertia, safety, elderly, and also the concept of personalized care and about the future. So primary care, I think, according to different healthcare services in the different countries, we are managing primary care, or we are understanding primary care from different angles. And I think I'm just providing here the example of my country in Spain, when we start working in that approach in primary care in early 80s. And before that, it was just considered not primary care as a specialty, it was general medicine. And then we also have to move to this new era where we have to be moving more for a primary care and community specialization. That is what we are having now. So this, as I said before, there are very many differences between countries because it's how they are providing care, and it's like based in a public health providing, or is maybe moved to the private system. So it's different realities. But in Spain, we move in that reality, and in the middle of 80s, we changed from a reactive approach to more proactive approach. I think this proactive approach, it was an approach where the person and the patient was in the center, and all the other professionals were around that person, trying to provide the best approach possible. So a primary healthcare team is like this composition in Spain, as you see, the social worker, dental care, health technician, administrative personnel, but mainly this unit, the GP or the pediatrician and nurse as a team providing care to the citizen. I think that we have different examples, and we have also, there are rural and urban centers. We start working in protocols, and also we start developing some first quality improvement programs. The first one in hypertension and diabetes in the middle of 80s, as I said. And I think that always that has been under, still at that moment, under an hospitalized center perspective. So we've been, because we, by tradition, our healthcare system is really based on the hospital's service and delivery. And we try to move from that perspective to a more primary care oriented providing of care. So at the beginning of 90s, we start with the primary prevention and healthcare programs. And that one's starting, as I said before, hypertension, diabetes, osteoporosis, COPD, asthma, depression. And I think that if we move to the diabetes field, I think that in primary care, we have many challenges. We know that around 50% of our citizens with diabetes are undiagnosed. And we know that for different population-based studies, also ones done in Spain in the 2012 and published in Diabetologia. Also, we know that before the diagnosis, we know that it's already a diabetes onset of around 7 to 12 years. And that it's important that probably in that period of time, maybe from primary care, we can, develop some kind of strategies that be more proactive in terms to detect those persons with a higher risk of that. We know also when we diagnose a person with diabetes, we know that almost 25%, they already have microvascular complications at diagnosis. I think it's important to also to know what is the value of the different tests we have available. There's a lot of work done on that. There are different tests that allow to understand if these tests could be feasible and also could be validated in different countries. And what is the use, how useful are that tests in our settings in terms to be used in a normal practice. But also I think it's very important to be very focused at the risk population, those ones that we know they are going to probably develop diabetes. And I think that here, all patients with cardiovascular disease, all of these ones with BMI over 30, when you have family history of diabetes, some ethnicities have a higher risk and at certain ages. And we know that some persons that have a previous, IGT or maybe gestational diabetes, or those subjects, those persons with a higher risk to have the disease. So if we follow the cornerstones of primary care suggested by Wonka, we know, and the Wonka is the World Organization in Primary Care, we know that it's important to be providing an holistic modeling, an holistic approach, person-centered care. And I think when we try to be with a community orientation, but I think that following that approach, what we can offer from primary care to our persons is probably a better campaigns, a better ways to identify and screen those persons with a high risk of diabetes. Also trying to implement those methods to decrease complications, probably have good programs that trying to, and validated programs, lifestyle that promote lifestyle changes, behavioral changes. And I think this is really crucial. Also, access to medications, and have all health professionals have good knowledge on how the medications works, and probably how we have to use it properly in clinical practice. And I think that, of course, and also we have to develop those strategies that allow us to coach those persons with chronic diseases to a better understanding and also living with a chronic condition. For that, I think it's important probably that from late 90s and beginning of the 2000, we have different programs. We start having more access to electronic clinical records, and that allow to have electronic clinical records and also guidelines implemented electronically. And I think that examples here from the UK and from Spain, where they try to implement in that electronic clinical records the QOF, or maybe in Spain, trying to implement continuous quality improvement programs, where we try to assess process and intermediate indicators, were successful and demonstrate that when we try to coach and to support electronically our healthcare professionals, they are paying more attention because they have systems that pop up and assist them and coach them in terms of their management of their patients. An example is that one that has been published in 2017 from my country, when we try to implement the actual guidelines that we are using in Catalonia inside the electronic clinical record, that goes with an improvement in different aspects. Here you have the different guidelines implemented, and non-user and user of that guidelines shows an improvement of the different indicators we try to assess on that pre and post control study. So it's clear that when we have tools that support and coach healthcare professionals, nurses, GPs, those ones managing the chronic conditions, that can be useful in terms of understanding and managing and coaching patients without chronic conditions. So I think it's important that when we are in that situation, we establish a continued quality of care standards. We also establish some other kind of tools that we can use it in this situation that allow us to, and also clinicians to understand in terms of safety, in terms of contradictions advice, and that has been introduced in our clinical records. But I mean, what is going on in real life? What's happening in our real life? And I think it's, we know that we have to face in primary care to more complexity. We have persons with more chronic conditions, and it's also increased the complexity of management of the persons. And I think if we follow that the scheme suggested also Wonka by Wagner many years ago, I think it's important to know that we have to put all the different efforts trying to collaborate and coordinate our delivery and put the patient together with a good connection with the patient and the healthcare system. As an example of what our challenges, actual challenges we have in the primary care in diabetes, we have to face with complexity. This is a very well-known figure when we see that diabetic persons have at least, when they have over 65 years old, 6.5 or more other chronic conditions. So it means that we are not just having to take care of diabetes, we have to take care of other things. Another concept is clinical inertia. We know, and this is a scheme we have here, when we are starting using, for example, insulin in primary care, and it's clear that we are delaying, and this is the first figure we have, time to insulin initiation between, in some countries, between 2 to 4 years. For example, in the UK, you see between 4.7 to 5.6. And there's a delay and a clinical inertia. And when you see in the other figure, what is the value of A1C when we start considering insulinization, you see that we are a lot far when we could be ideal. We are over 8, in the UK you see values around 9.4. This is also observed in other countries like Catalonia, Spain. Here, for example, I showed you the data published in Catalonia, when you see that when we starting, or we considering, and this is a data from all the Catalonian primary care centers and all the citizens with diabetes in the primary care system, and you see that this is more than 300,000. And you see here that when we are considering to start insulinization with a values of A1C above 9. So I think this is a lot of space of improvement on that. So clinical inertia is also known by this study that could be in that kind of design, we can correlate if this clinical inertia can emerge, can conduce can drive to an increased risk of complications. And this is important concept to keep in mind, because when you know that you have clinical inertia, you are delaying intensification, but that could have consequences. That is really important. It's a very strong message to keep in mind that you have to do something else. You have to do some action. This is a figure that has been presented last week at the ADA. This is a summary of all the studies running, already some of them published, but that introduced the concerns about safety. And also the benefits of some of these compounds are showing in terms of managing the diabetes. So I think it's important that safety is something that can be considered, but cannot be a barrier in terms to intensifying therapies. And these studies are showing that the majority of compounds we are using now, the new compounds for diabetes, injectables and non-injectables, are safe. And some of them also goes with some additional benefits. And this is also translated into the new guidelines and recommendations. Another thing to consider is in terms of aging, in terms of age. We are managing majority of our patients in our countries are other adults, and that it means that the prevalence of diabetes on that persons is of course higher, and could be around 25% or higher in persons above 70 to 75 years old. That it means that a quarter of patients we are visiting of that range age have diabetes. And when we try to intensify the benefit we can observe it when you are treating patients at that age, compared with those young persons, is very different. So it means that the benefit we can obtain in that ages in terms of intensifying therapy is less than what we can observe in youngs. So we reserve here, we move back, or we put the message in the other side. Here, it's important to identify young persons with this chronic condition and be very tight at the early phases of the disease, because it's when we are going to observe more benefit. Another concept is frailty. Frailty, and that has been described in some international recommendations, like those ones moved by the gerontologists, like, for example, Alan Sinclair and his team, and also with other guidelines. Also, the Primary Care Diabetes Europe, my group, also suggests a position statement on that. And I think frailty must be assessed in our elderly patients, because when you have frailty detected, the targets you have to consider for those persons must be different. It's different approach. Also, what happens with the kidney? And this is in a study published in Spain, and what is the prevalence of kidney disease? And I think we are testing sometimes A1C, other parameters, as for example, eGFR, kidney function, or maybe urine albumin ratio, where we can observe the damage in the kidney. But sometimes we are just testing and not reacting. And I think it's important that the prevalence of these chronic conditions and this damage in the kidney or diabetes kidney disease is more high than we expect. And I think it's important when we have this kind of observations to try to provide an approach, a different approach, and the adjusted approach to that kind of observations. So again, this is a very strong message. We have to put the citizen, the person with the chronic condition, in the center. And we as a healthcare providers, we have to understand what is around that situation and how we have to manage, how we have to understand the situation, how we have to do the different approaches, how we have to agree in a plan, how we have to share with the patient our goals, and then the patient also must be involved, moving far from a paternalistic approach, implementing and also coordinating with the patient, or just adjusting for the different realities, this trajectory of the diabetes disease management. This is a figure that you know perfectly, is the last ADA ESD recommendation. And I think just this is my last messages. I think it's important to know that nowadays we are providing care, and I think it's very important that when we are providing recommendations, advice, or care, we have to provide that kind of products, that kind of activities that have evidence supporting behind. And I think that programs like in Spain, the patient expert patient, or in the UK that has been validated, the expert patient program, the Desmond program is an educational program implemented and built in the Leicester University and the Leicester Diabetes Center that has been implemented around UK. I think it's important initiatives that we have to consider, because we don't have to invent anything. Maybe we have to adjust, we have to validate in our country, but we have to do it. We have to forward some initiatives that already are very robust and they are bringing with a good value behind. Also, there are many different initiatives in many countries, and also in your country in India, about diabetes prevention. It's important. It is an initiative, and we know that the initiative works. We have to follow. It's not just that it has been published in a paper, but when something it works, we have to be committed to be implementing that initiative, that thing that we know it works. And I think that we have to take care about how primary care agenda and endo and diabetology agenda have a similar roadmap, a similar trajectory, trying to put all the force together to try to be centered on our patient-centered approach and trying to provide the best care possible. I think that now we are living in a digital life. We know that because this pandemic has shown how important has been digital life to be living, and also I think there's no other excuses to implement digital solutions in the real life. So I think that in terms of education, monitoring, etc., education, digitalization is here. It's not a dream. It's here, and we have to investigate. We have to implement that solutions in real life as much as possible. I think also that is important to consider how we are doing benchmark of that initiatives, how we are benchmarking the best practices, and how we are understanding and how we are learning from that best practices. So it's important to have this personalized approach. So as I said at the beginning, I prefer to be more solid in a positive message, not fixing on the ground what is in the chat. I would like to move to the challenges, to that opportunities we can consider to improve. So as a summary of my presentation, it's clear that type 2 diabetes management is a priority in primary care. I think that is an important impact of the continuous quality improvements in the UK, in Spain, and in other countries, okay, and electronically implemented. I think that concepts as complexity, personalized care, safety, clinical inertia could be considered as barriers in terms of primary care clinical practice. We have to identify, we have to coach our colleagues to allow them to understand that ones and to take that ones as an opportunity to learn and to improve, okay? Not as a barrier, not as something that keep us like stable and not reacting. And I think it's important that we have to create a balance between diabetes complexity and the care we are providing. We have now a lot of tools that allow to understand or let us know, allow us to identify the complexity of the patients we have in front of us. We have to provide the care adjusted to complexity. We have to provide a strong, probably, approach to those persons at the early situation of diabetes, young persons, and we have to provide another approach completely different with elderly, with older adults with diabetes. We have to abandon. We have to provide the approach, the appropriate one, with the appropriate benefits we know that are behind that approaches. And also, and my last message is implementing technology, using technology to support in this new era where we are now trying to manage and to coach persons with diabetes from the primary care field. And this is my last message. Thank you for listening.
Excellent presentation, Dr. Xaviers. I fully agree with you that diabetes has to be managed well at the primary care level, because the first few years a diabetes person spends with the family practitioner or the primary care providers. And if they treat the disease well, aggressively, I think most of the job is done, because the complications set in very early. You rightly said that the inertia needs to be addressed and the importance of the EMR. Now the session is open for the questions. I'll start with the one. Has the pandemic of COVID changed the way you practice in terms of the digital platform use or in the terms of the medications that you use?
Not in the I mean, the COVID pandemic also brings some alerts in terms of you are in the sick days. The concept of sick days sometimes require some update in clinicians because they are not really aware about what it means sick days and what are the medications that probably require maybe to be stopped or to be down titrated or maybe some coaching for patients. I mean, if you are on insulin and you are on SGLT2 inhibitors and or you are in SUs, probably if you are in sick days, you are reducing your carbs intake or something is important, some messages, important points of education we have to be understanding for the next spread or for whatever. But I mean, 6 days, I think is an important concept to review and to keep all of our colleagues updated, healthcare professionals, nurses, GPs, etc. In terms of digitalization, of course, I mean, we are not controlling our patients in primary care. The centers were closed. Everything was closed. Imagine, and I've seen now in clinic, these first 2 weeks, I've been doing clinic twice a week. I've been very surprised about the consequences of COVID in some specific persons. I've seen, and this is very rare, diabetic foot ulcers in 3 patients that they were not consulting because they were scared about the COVID and they were delaying and they had that problems for more than 1 month. It was in this period of alarm and that could be consequences. So it will be important to probably to identify and to understand what happens during the COVID pandemic, what has been the problems of the consequences, and probably for the next phases, probably more prepared, aware, and informing the citizens what are the reasons to call the center and to come to the center. But now we have been in a very, like an under of earthquake of information, a lot of contradictories, a lot of uncertainties, and I think it's an area we have to explore in the next weeks and months.
True, very true. Rutul, do we have any other question?
Sanjeev bhai.
Yes.
Yes, Francis,
Yes,
fantastic talk.
Yes, wonderful talk and very important too, because he rightly pointed out that diabetes has to be managed very well at the primary care level, which does not happen in our country.
Yes,
so I think more and more work needs to be done in that direction.
And that's the reason, you know, we had collaborated with Primary Care Diabetes Europe.
Yes.
And we will be having one big meeting with PCD. And I'm a big fan of PCD actually, and Francis is a close friend of mine. I just wanted that how often in primary care in Europe they use GLP-1. The uses of GLP-1 at our primary care level is very low.
Mm-hmm. Yeah. So, yeah, that's true. That's true. I mean, on the figures we have, for example, in Catalonia, is we are using GLP-1 receptor agonists and the injectables because we don't have the oral one already. We are using below 2%. Okay, in the total amount of type 2 diabetic persons. And if we go, for example, for one of the restrictions, it will be BMI, and we consider, for example, BMI of 35, for example, that is not on label. Label it says, because so many countries are putting conditions in terms of reimbursement, and they're saying that if you are not above 30 on BMI, you cannot, this medication is not reimbursed. Other countries say 35. But if we know and look at what is the BMI, the average BMI of citizens with type 2, or the percentage with BMIs above 30 or 35 is around 50 or 60%. So it's clear that primary care physicians and also endocrinologists are not really using this compound, this injectable in the real life. I think that now it seems that there's more movements to do that, but there's a lot of, sometimes I think, reluctancy to use that compound, sometimes in terms of cost, because some countries have cost control in healthcare providers, but in other countries it's because they feel a little scared about using an injectable because they still don't understand well how this compound works. So it's a lot of education needed, and also put in place what are the benefits of that medications compared for other injectables, for example, of course, insulin, or maybe other orals that are not having these benefits in terms of complications. An example is there's a high use of incretins in terms of DPP-4 inhibitors around. And of course, we know they are very safe, but we know that at the same time they are safe, they are not having, I mean, potential benefits on some cardiovascular or other sides, complications. No? So I think that, of course, put in place what is shown on the different cardiovascular outcome trials and just revisiting what on the latest recommendations, as for example, the latest version of the latest position statement published 2 weeks ago from PCDE, it will be a good exercise to do to know how we can understand how useful could be these different compounds in terms to be introduced in clinical practice.
True.
Sorry,
I think we are coming to the end of the session. Thank you very much, Dr. Fransesc.
Thank you very much.
And we look forward to meeting you personally once all these COVID things go away. And we wish and we pray for that.
Sanjeev, you remember last time when we were in the Barcelona, only he suggested and he guided us where to go.
Oh, yes. So we enjoyed Barcelona very much.
Francis, now see you in the PCD symposia.
Okay.
There. Come on. See you.
Come on. Okay. Bye-bye. Talk to you later. Thank you very much.
Thank you.
Thank you.
Dharmendra, you take over.